Hello again. This is your radiologist speaking. So, for this session, we will tackle lower extremities. So, consideration again is we request for x-rays according to the uh, regional anatomy of the lower extremity. So, by regional anatomy, we have the pelvis, the hip, the thigh bone, the knee, the leg, ankle, and the foot. So that is how we request for our X-ray X-ray views, and also uh, we request for at least two views, the AP and lateral views, commonly, except in the foot, where we also prefer the oblique views so that there will be no superimpositions of the digits. So as to pelvis, this is the AP view of the pelvis, and you will see the different anatomical points to consider in this picture. And when you compare it with your gross anatomy studies, you would see the same features, the same parts. So on the right hand side picture, you will see the general areas of uh, origins of the different muscles. On the iliac crest, you it's where the abdominal muscles are attached. On the anterior superior iliac spine, the sartorius muscle, anterior inferior iliac spine, the rectus femoris. On the greater trochanter, you have the gluteus medius. On the lesser trochanter, the iliopsoas is attached. On the ischial tuberosity, the hamstrings. On this around the symphysis, you have the adductor muscles. The importance of knowing these general areas of attachments of these various muscles is that when you see specific uh, avulsion fractures, avulsion means it has been violently detached from its from the attachment. So when you see avulsion fractures on these areas, then you generally know which muscles are involved, especially when you are an orthopedic surgeon. So you have to know uh, these general tips. As to the hip joint, an AP view is mostly mostly enough already to see your anatomy. But sometimes we see suspicious fractures of the neck or the acetabular joint, the acetabular rim, that we may want to see another view. We request for an oblique view of the hip, or we call it a Jude view. The Jude view, in Jude view, the affected side is rotated roughly 45 degrees anterior, and this is where we see suspicion of acetabular fracture. And on Jude view, you are able to see more clearly the outline of the acetabulum, and sometimes we see more clearly the neck compared to the AP view, especially when you have a trauma patient. The patient cannot fully extend his lower extremity, so you have to play around with two views. So again, Jude view or oblique view, that's one special projection of the hip. In the study of the pelvis or the hip, we sometimes have difficulty deciding whether the hip is normal or not. So in pediatric cases where the epiphyses have not fused yet, you will see spaces. This hip, this what you call tri-radiate cartilages on both sides of the pelvis. So this is where we draw a horizontal line across this tri-radiate cartilages. We call the Hilgen-Reiner line, and a second line which extends along the acetabular roof. This forms the acetabular angle or index. So for a normal hip, it is usually less than 22 degrees in this young age group. If you have suspicion of developmental dysplasia of the hip, you may have an angle of more than 40 degrees, and you may see that the femoral head is not uh, not very close to the acetabulum, and there is widening of the hip joint. The acetabular index is also useful in adults. In adults, since the triradiate cartilages have already fused, we look for the radiographic teardrop. I really don't know how to show the pointer. The pointer is showing on my screen, but I hope it records on the recorded slides. So I hope you can appreciate uh, the picture being pointed at. That is the radiographic teardrop. So this is where we draw a horizontal line across the inferior edges of these teardrops, and we draw a second line across the acetabular roof. So the normal range in adults is 33 to 38 degrees. So angles more than 47 degrees are seen in patients with acetabular dysplasia. You might wonder why acetabular dysplasia in adults. Well, probably these adults had dysplasia when they were younger, and they had neglected it. So you might still see it in adulthood. More commonly in adults, uh, the acetabular angle is useful if you have high index of suspicion for trauma of a particular side of the hip, where you can't decide if the hip is subluxated or dislocated. So this may help you decide, because a widened acetabular angle in adults may suggest fracture of the femoral neck, subluxation, or dislocation of the femoral head. So another useful tool is the Shenton's line. A Shenton, a Shenton line is an imaginary curved line drawn along the inferior border of the superior pubic ramus or the superior superior border of the obturator foramen and along the inferior-medial border of the neck of the femur. So the yellow curved line represents the Shenton line. So a disruption of this line you may see in cases of fractures of the femoral neck, subluxation or dislocation of the hip joint, as in the picture represented on the right side of the slide, where the Shenton line is disrupted. And note that Shenton line was first described in 1902 by Dr. Edward Shenton. He is an English radiologist. So a lot of radiologists like to call certain signs with their names. Other useful studies of the pelvis are the inlet and the outlet views. This will help you see the integrity of the pelvis. Look for widening of the sacroiliac joint or widening of the symphysis pubis or fractures of the pubic rami. So in the upper X-ray picture, you will see a fracture of the pubic rami in the right. Also widening of the symphysis pubis, so suggesting there is a diastatic fracture of the symphysis pubis and of the rami. So this, and you try to look at the sacroiliac joint if they are widened. If the sacroiliac joint is widened and the symphysis pubis is also widened, then you might have what you call an open book fracture of the pelvis. Perhaps you will encounter this later in your clinical studies, advanced clinical studies in probably in third year in surgery. So for now, it's good to know that you have these particular views that may help you diagnose that fractures of the pelvis. In the lower X-ray picture, you would also appreciate a fracture of the right inferior pubic ramus. So I'm not sure if my pointer is showing in your recorded presentation. Another useful radiographic procedure would be the angiography. This angiography is a procedure in which we inject a dye to the arteries or the veins. But generally, angiography means you are injecting into the arteries to study the blood vessels of a particular area. In this case, we are studying the lower limb, so we look at the integrity of the vascular system, the lower limb. So this is useful in cases of trauma where you are contemplating whether to save the limb or to amputate it, depending on the integrity of the vascular supply to that particular limb. So if there is disruption of the vasculature of the particular limb, then the surgeon may opt to amputate because it would be very difficult to repair and reconstruct the vasculature of the particular limb. You may also be able to distinguish the vascularity of a particular cancer affecting a particular limb. So you may be able to plan out the surgery or whether you would opt for treatment by interventional radiology, interventional radiology. You know. So in CT scan or MRI, you could also do angiography, but these are special features of the CT or MR, wherein the machine itself has a software to reconstruct the vasculature of a particular area of study by just relying by eliminating the other structures in the picture, like what you see in the rightmost X-ray picture, where you can only see the vascular tree of the lower limbs. So that's already a reconstructed image in CT scan. In the central images, those are images from MRI angiography. They are reconstructed images. So that's the beauty of advanced technology now, because it's minimally invasive already, and it gives you a very good high resolution pictures of the area of interest. So going to the femur, just like uh, in the study of long bones, we request for an AP and lateral view because we want to see a more or less a two-dimensional representation of the long limb. So you have to request an AP and a lateral view. So another reason for this is because we want to know how bad the displacement of the fracture is, whether it's towards the front or the fracture is towards the back, so you will know how to mend the broken bone. So from the femur, we go to the knee. So the same anatomical structures in your studies in gross anatomy. So please kindly go through the different parts and familiarize yourself with the same anatomy. So on the AP view of the knee, the patella is superimposed on the distal portion of the femur. So on the routine studies of the knee, the APL views, you only see the patella, the side of the patella on the lateral view. We have this certain condition, but you don't have to uh, memorize this. It's just a way of example. We have an Osgood-Schlatter's disease. This is a condition in young adolescent athletes, usually in repeated trauma of the knee. Usually in they are athletes, so they have this repeated trauma of the knee. Specifically the repeated avulsion of the patellar tendon insertion at the tibial tubercle. So it causes pain and swelling at the tibial tubercle. So when you have a patient soon in the future, you know who is an athlete and he has this painful swelling of the knee, especially around the area of the tibial tubercle, and it has been going on for some time, then you might suspect this Osgood-Schlatter's disease. So take a good look at the tibial tubercle. The tibial tubercle will be in varied degrees of avulsion, separation, or fracture. So that is Osgood-Schlatter disease. Another useful study of the patella would be the skyline or sunrise view, especially if you have a very high index of suspicion of an injury in the patella. But on looking at the AP and lateral views, quite you don't quite uh, appreciate any fracture, so you might opt to request for a sunrise view. So the sunrise view, as it describes, it looks like the patella is rising over the horizon in between two mountainous background. So, so that's how it came to be called a sunrise view or a skyline, because imagine those two mounds of the tibial malleoli. So as the high-rise buildings. So, well, that's how they probably view that. And how to position skyline view or the sunrise view in X-rays is seen on the rightmost picture. There are three techniques being employed, but I think the third the third technique, where the patient is lying on his back with knees partially flexed and holding the X-ray tube, is probably the most convenient for the patient and as well as the technologist. So, and we go to the leg. So the same AP and lateral views, the same anatomical features, so the same parts you see on the gross anatomy study. So please go over the various parts. So because they might be asked in your practicals. In the practical exam, it's just simple identification of particular part of a particular limb, or so it's not hard. I won't be asking complex questions on practical. Yeah, I will just be asking practical questions because it's a practical exam. So I'll be asking practical tips or practical what you would probably retain after this lecture. So don't worry about very complex questions from me. So for we go to the ankle, we the usually the orthopedic people order, oh, also the people from surgery or order a ankle series. So ankle series, it has three views, different views: the AP, the usual AP and lateral views, the routine AP and lateral views, as well as a Mortise view. We will go over the Mortise view later. So on the right hand side of the slide, this is how we position the different techniques in X-ray. For the routine ankle APL views, these are the anatomy. This is the anatomy of the two views. And then to discuss further what is Mortise view and how it came to be. So Mortise view is the most pertinent projection for assessing the articulation of tibial plafond and two malleoli with a talar dome, otherwise known as the mortise joint of the ankle. So the two malleoli, the medial malleolus of the tibia and the lateral malleolus of the fibula, and the tibial plateau is the mortise, and the talar dome is the tenon. So it is a carpentry joint at the bottom picture. So mortise is defined as a hole or recess cut into a part which is designed to receive a corresponding projection called a tenon on another part so as to join or lock the parts together. So that is a mortise and tenon joint in carpentry. So the mortise is the hole or recess, whereas the tenon on the human anatomy is represented by the talus. Okay, so I hope you appreciate the mortise view. So routine positioning of the foot is AP and lateral views, and we also have the oblique views because we wouldn't want the digits to be superimposed on each other so that we are able to get another view of the digits in question, because on lateral view all the digits, the phalanges, the metatarsals are superimposed on each other, and so that's how we position the foot on x-ray. So again, the anatomy of the foot doesn't is not far from what you are studying in gross anatomy. So what is important to note in the ankle are the ankle bones, just like in the wrist. So the ankle bones form a unique form of joint. So composed of this is a complex joint composed of several bones. So the ankle joint is formed by, on the farthest row, the outermost row, you have the cuneiforms, medial, intermediate, and lateral. That's from the inner part of your foot, which is we call medial to the lateral part of the foot or the side of the foot. So medial, intermediate, and lateral. And on the lateral portion of the foot is the cuboid, after adjacent to the lateral cuneiform. So take note, cuboid is on the lateral side. Then on the proximal row of ankle joints, you have the navicular, which is the curved bone. Then the talus, which articulates with the tibia, and the calcaneus. Okay, so I hope you get that. So on the foot, in the lateral view of the foot, what is clearly seen of the ankle bones are the calcaneus, talus, and navicular. So the cuboid and the cuneiforms are superimposed on each other, and it's not possible to distinguish one from another, except a portion of the cuboid. When you have high index suspicion of a injury of the calcaneus, and you don't see the fracture on the lateral view of the foot, but you have a very high suspicion of trauma to the calcaneus, you might consider requesting for an eggshell view of the calcaneus, or what you call the plantodorsal view of the calcaneus. But for practical matters, just call it an eggshell view, because this is uh, how we see the calcaneus on its eggshell side. So you might any fractures to the along the eggshell orientation of the calcaneus, you may not see it on the other views, on the AP view. So this is a special view of the calcaneus when you have a very high index of suspicion of trauma to the calcaneus. Okay, so I guess we have reached the last slide of this session, and I hope you would uh, take the extra time for self-study to go over the different anatomical parts of the different parts of the bones, for both the upper and lower extremities, because some of them might be asked in the practical exams. But don't you worry, I won't be asking complex questions or difficult questions in the practicals, because like 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 the name itself, practical, so I would only ask for practical matters that you would remember, hopefully, when after these lectures. So as a parting wisdom, common sense is not a gift accordingly, because it's a punishment. Uh, because we have to deal with everyone who doesn't have it. So unfortunately, this uh, you might you might consider this true, because nowadays a lot of people have lost their common sense. So, and we have to deal with them, and it's annoying. And and going to that, in particular, these people who are not wearing their masks, these are the personality types that have lost their common sense. So please wear your mask properly. It should cover your nose to your chin. So these are the COVID personality types you would encounter in public. So again, stay safe, everyone, and stay healthy. Eat nutritious food to build up your immune system. Take your vitamins if you have to, and hydrate well. Drink a lot of water, because hydration keeps your body healthy. So I hope to see you one of these days, whether online or in person. So until then, so see you, and good luck in your bi-monthly exams.